Very warm welcome to our 24th Rare REV-inar. I'm Nicola Miller, Editor-in-Chief and Creative Director here at Rare Revolution, and I'm supported today by my colleague Becky Pender, who as always is working on the background on all of our tech. Today's REV-inar is sponsored by Childhood Tumour Trust, who this year are celebrating 10 years of supporting patients and families living with neurofibromatosis type 1. This is one of a series of collaborative activities that will be running throughout 2026 to celebrate this important milestone, and has been supported through funding from Alexion, AstraZeneca and Springworks Therapeutics. Content and themes have been developed independently though by Childhood Tumour Trust and us here at Rare Revolution. We're also thrilled to let you know that today's REV-inar has been CPD accredited and will send out an email post-event for anyone who wants to gain a certificate of attendance. There's many of you watching live today, which is really fantastic, and we'll try to get some questions at the end, so please do use the Q&A function at the bottom of your screens to ask any questions, and we'll try to get to as many of them as we can. Any that we don't get to, we will respond to afterwards back through email to let you all know the outcome. Today's Rare REV-inar will bring together professional and lived experience expertise for open discussion around diagnosis, care, transition, complications and future needs when living with NF1. The webinar aims to improve understanding on both sides, strengthen relationships and support better outcomes across the NF1 community. And I'm delighted to be joined by a really incredible panel of speakers today. Bev Henderson, who is a rare parent to a child with NF1 and also brings healthcare experience as a health visitor in the NHS. Lily Sandell, who is a CTT Youth Ambassador who lives with NF1 herself and is involved in a range of programmes and initiatives, and is also, I know, the world's biggest Starlight Express superfan. Vie Portland is the founder of VIP Empowerment, where she helps people find their fabulous. And she's also an author and hosts weekly storytime sessions with Childhood Tumour Trust. And returning panellist Dr. Will Evans, a GP in the NHS, whose varied research interests focus on rare and hard to diagnose conditions. And he's also been key in the development of the recently launched care guidelines, which we're going to touch on today for NF1. Thank you all for joining us. It's great to have everyone with us this afternoon. So all of that said, let's dive in straight in at the beginning, I think, with diagnosis and early intervention. And I'm coming to you first, Bev, because you're really on the front line as a healthcare, as a health visitor and someone with personal lived experience. So it'd be great if you could talk us through really what are those early indicators to look for and what sort of immediate support is really essential for new parents receiving a diagnosis of NF1.
Okay, yeah. I just wanted to start out by saying I'm talking from my experience probably, and I think what's probably maybe not everybody knows who hasn't got experience of NF1, but everyone's symptoms and health problems are really quite different. So I'm just speaking from my experience and happy to be corrected or information added from other people with their experiences as well. But I just want to make sure people understood that. But I think quite commonly, unless there's something more obvious symptom-wise, it's birthmarks we're looking for really. So it's cafe au lait, which are the light brown. Birthmarks can look different on different skin tones though, so just to be aware of that as well, I suppose. So that's how my daughter was sent for further tests to be then diagnosed with NF1. But I mean, as health visitors, we do look for birthmarks routinely. So every baby should have a newborn exam, sort of a check from head to toe before they leave hospital, if they're born in hospital or by a midwife. So that's the first point where you could spot birthmarks or any symptoms of NF1. And then we check at 2 weeks. The GP checks at 6 to 8 weeks again. So those all babies are sort of seen naked to be weighed and stuff like that and to be checked over. But to be honest, birthmarks aren't always present at that age anyway. And for us, that was it was about 8 months when the sort of the number of birthmarks met the criteria for further investigation for our daughter. So yeah, we look at that quite commonly. There's other sort of, I guess, a lot of my colleagues don't really know about NF1 until I talk about it,
Yeah.
or the odd one will have come across it in a child. So it's really varied in the response you'll get as well, actually.
You mentioned about different skin types there. So how much
yeah.
is that something that's very difficult to identify in children of different colors? Like, and so, what sort of extra sort of
Yeah,
level of awareness do you need to have when looking for those
well, I
signs?
think that that's an area that needs to be developed as well because historically, I think it is being tackled now, but historically in textbooks and things like that that doctors and nurses learn from, it would be a white person with pale skin, and that's how for rashes, for all sorts of symptoms, it is being addressed and is being, but not probably not quick enough really. But
Was it
yeah.
something you were aware of through your professional background before you had a child with this condition and went through the diagnosis process yourself?
Yeah, I had heard of one person, but from a distance, if you know what I mean, not
Mm.
directly. So I wouldn't really have been able to reel off the list of diagnosable criteria or anything like that. Um, yeah, so just more that we have ex most health visitors should have experience on what birthmarks, what different birthmarks look like. But yeah, I wouldn't say that it's not in um standard training or anything like that.
So, from your
Um,
perspective, what would be beneficial or what more can be done to ensure that other health visitors can feel as confident as you would now do in recognizing that?
I think even with birthmarks, not everybody's confident in,
Mm.
across different health professions as well. So quite often we're looking at whether a birthmark is a bruise or, what is it? Is it a different health condition? So sometimes people can be quite nervous about that, really, and refer on for like
Mm.
a further look at that, which would then pick it up. But yeah, there's no standard sort of course in rare diseases in health visiting training. Um, so yeah, it could easily be put into um a course. It wouldn't take long to look at that, to have a section on rare diseases in general, perhaps. I know Vanessa recently did a blog for the Institute of Health Visiting, which is a really well respected um I can't think of the word. Like
I know
I was
what
going
you
to say service, but it's like
Yeah,
a
organization.
organization, thank you. Where we get resources from, we get membership, to,
Mm.
and sort of it's like evidence-based practice. So I know Vanessa's written a blog there, so that will be seen by a lot more health visitors. But they do
Trying to
like
raise awareness.
parent tip sheets and professional resources. So something like that could be created that I think people would find useful if they're like, we're gonna Google what
Yeah.
does this mean? Not saying that we all Google stuff, but yeah, then you could be, go to a trusted resource on it of what to do next.
And I guess going through those kind of affiliation organizations is a really good starting point, isn't it? Because you get access to a big cohort of that particular, like the
Yeah,
health
and
visitor specifically.
they do conferences and things like that. So I know Vanessa's been at, I think CTT have been at had a stand at them sometimes. So um yeah, so I mean, I think there's a lot of resources on the CTT Trust website, which I'm personally, obviously, I guess I've got a personal investment here, but I was hoping to sort of give my colleagues a bit of a point in the right direction, bit of a maybe a little teaching session. But yeah, it's difficult to uniformly like make sure every health visitor has it. We have a responsibility as ourselves to look these things up. Um, but yeah, so the course, a little section in the course would be good. Um, and the Institute of Health Visiting would be the point
Thank you, Bev.
that people
Appreciate
look
that.
into. In
Will,
terms of
sorry, go ahead.
like in terms of new support for new
Mm.
parents, like so if we do discover birthmarks, I think there's a bit of a pre-diagnosis and post-diagnosis probably difference. So you don't want to lead people down a path of a certain condition before you've got a diagnosis, I suppose, but thoroughly recommend CTT for any support
Yeah.
um, for parents once you've got that diagnosis, or if you're going for a test of NF1.
Yeah, I think it's an important thing, isn't it? Balancing out how much it's appropriate information until you have that confirmed diagnosis, and then having really good signposting to, so like you say, not having that tendency to go onto Google and Wikipedia, but to actually go to a really reliable source of good information.
Mm.
Amazing. Thank you, Bev. Will, I'm going to come to you, and great to have you back with us again. Thank you. And Bev mentioned there about the diagnostic threshold as well of having more than one sort of early indicator. So what happens in a situation where maybe you've got a child that's presenting with some cafe au lait marks, but they don't quite meet that two feature criteria? What does best practice look like in terms of how you follow up on that child so that they don't fall off the radar, but recognizing that they're not quite meeting the diagnostic criteria either?
Yeah, no, thanks, Nicola. Yes, I think it's probably, and Bev's already touched on this, is that actually the kind of a lot of the classical features of NF1 are often not present when children are very young. So um, the cafe au lait patches can be, but then they typically develop in the first few years. In additionally, neurofibromas tend, if they're going to occur, tend to occur from teenage. So you would not the kind of cutaneous neurofibromas, the small ones, not so much the bigger plexiform ones, which we may talk about later, but the cutaneous ones and the subcutaneous ones don't tend to develop until the teenage years. And then another feature that we look for is a thing called axillary freckling. So freckling in areas that are not exposed to the sun, in the groin and in the armpit. Um, they often, again, are not present when they're young. So, and cafe au lait patches having two or even three are quite common. You know, there'll be lots of us on this call who have one or two cafe au lait patches and do not have neurofibromatosis. I mean, therein lies this big challenge. You know, that a baby with one or two cafe au lait patches will almost certainly not have NF1, but they might have. So there needs to be some way of following up those children. So I guess having so, for example, if a child is referred into a genetics clinic because they've got certain features, there are two ways of making that diagnosis. So, if you have a child, let's say who's 3, and they do not quite meet the diagnostic clinical criteria of having 6 or more cafe au lait patches as one feature, and or axillary freckling or Lish nodules or all these other bits, which, if need be, we can go into, but they don't meet that criteria, and they have a genetic test, and the genetic test is negative, they could still have neurofibromatosis. About 5% of people after genetic testing, we don't find a variant. So typically what those children do is they come back when they're 5, 6, 7 years for a review. And if they still don't meet the clinical criteria at that age, it's then felt very unlikely that they have neurofibromatosis. So we have this. So in a way, that for kind of first contact clinicians like health visitors, like GPs, like I am, yeah, we have this challenge. Is you have a child brought to you. First of all, you have to identify that this is a cafe au lait patch. I think we just talk about it as if that's straightforward, but there's lots of pigmented skin changes which can be caused by all sorts of things. So you need to feel confident that you're seeing what you're seeing, and then have some idea of, okay, let's bring this child back after a period of time to see whether, or safety net very clearly with the parent. This is what I think this is. This is fine, but if there are multiple other ones start appearing, you must come back and then refer on.
Would it ever be standard, for example, if you had, say, a child with maybe 3 or 4 that you might think, well, they don't quite meet the criteria? Would you ever ask the question around whether parents or siblings have them? Because I understand there can be quite a strong genetic link with, multiple generations. So is that a sort of standard question, or does that sit within the guidelines to ask those sort of questions around family history?
Yeah, I mean, you certainly should ask that, absolutely. I think if a child has more than 3, then the child should be referred from primary care into pediatrics, which is actually the next step. Um, um, but absolutely, yeah, I'll ask about the family history. I mean, having a family history of NF1 is one of the counts as one of the two things. And obviously, the scenario which, if we know a parent has a diagnosis of neurofibromatosis, and certainly if they have a genetic change, then you can do a genetic test in that child, a targeted test for the known familial variant, even when the child doesn't meet any clinical criteria. Because if they have the change, then they have neurofibromatosis.
And often it works back the way as well, doesn't it? When a child is diagnosed, then sometimes that leads to the parent being diagnosed. So,
Yeah.
yeah.
And therein lies exactly which there is variability, and there can be significant variability even within families. So as you say, a child gets a diagnosis, um, And I think my understanding is it's approximately about 50% are de novo, so what we've got a new change, not inherited from a parent, or 50% are passed on. So so if you find a child who's affected, then yes, absolutely testing both parents, and certainly if they have clinical features, is a kind of standard approach.
Amazing. Thank you, Will. Lily, I'm going to come to you. Obviously, at 18, you've been living with NF1 for quite some time now. What are your kind of early memories around being diagnosed and that kind of early intervention? What age were you diagnosed? What did that look like for you?
I was diagnosed at 6 months old, so I don't really have any memories whatsoever.
No.
But because Mum also has NF1 and it's quite a long line of genetically going through the family, she knew what to look for and was being supported by a geneticist, and knew what symptoms to look out for. So we were able to get the diagnosis quite early on for me. And then from being like 6 months old to age 7, I was just having like regular eye tests and checkups with the paediatrician. And then age 7, I got diagnosed with a brain tumour after having loads of tests on my eyes and getting unwell. And then from then on, it was having more appointments at other hospitals and having lots of scans and seeing lots of other doctors to treat my hydrocephalus that I got diagnosed with because of the brain tumour. The checking on the tumour, still having the regular eye tests and paediatrician checkups and everything.
So you're quite closely monitored now, aren't you? You're very
Yes.
And thinking about kind of some of the early interventions that you've had, and also with the work that you do as an ambassador, what do you see as being things that have had a really positive impact on young people in terms of their journey? Are there things that you think have helped them with come to terms with their condition and that diagnosis?
I think definitely having charities like CTT really helps, because until we found CTT in lockdown, we didn't really know. We obviously knew about NF, but we didn't know so many other things about it. Like with the itching, we didn't realise that was a symptom of the NF, or can be. And growing up, I understood I had it, and it was just something I kind of got on with, because that's what, during when Mum was little, it was what she did, because there was no knowledge really about NF1 when she was younger. And then since finding CTT, we have learned so much more. And since going to one of the specialist NF treatment centres, it's just constantly learning about different things about the NF1, which is really interesting and useful to find out.
And Will mentioned about the variability there. So was it surprising for your parents when you had the involvement with your brain, if that's not something that your mum had experienced or sort of previous generations? Did they have an association that those kind of things could be associated with NF, or was they kind of focused more on the skin, or like what was their understanding of those elements?
I'm pretty sure Mum knew that it could, like, you could have loads of different symptoms. Yeah. And then obviously when I did get diagnosed with the brain tumour, I think it was quite a bit of a shock, because Mum hasn't got that, and I don't think many of the family members have. So it was a bit of a shock. And then with the hydrocephalus as well, because of where the tumour was and it growing a cyst, meant that I had to have shunts fitted.
So it was a big steep learning curve for all of you then, and I guess you're still on that journey, really, aren't you?
Yeah, because we're constantly learning new and different things, with new research that's coming out, and just it's constantly learning.
Yeah, well, it goes back to what you said at the start there, Bev, about that importance of good signposting. Vie, I'm going to come to you because, I mean, someone whose bio mentions making people more fabulous. I mean, that's, I know you do some great work in terms of working with the young people, particularly around confidence and self-esteem. But, from your perspective, how important is that and the messaging actually around diagnosis and helping people have positive associations with their condition, building and maintaining positive self-image post-diagnosis?
I will firstly say that I was also born with a rare disability. So if I intersperse we with they, it's not deliberate, it's habit. because, so I come at this from a lived experience as well.
Thank you for sharing.
I know a lot of people in our community, and I think this is true in any community where a diagnosis is given, is to focus on what we can do and not what we can't. There's a whole dialogue around, oh, that disabled person can't do this, and they can't do this. But to encourage us to thrive, we need everyone to go, you try it and see, because that gives them the confidence to try things. It doesn't make them feel like a victim from the beginning that they can't do these things. Tell them from the beginning that they're lovable as they are, that nobody is the same as anybody else. So that does, just because we have this diagnosis or that diagnosis, they're still fabulous. It's just that they're different, and difference is wonderful. Share those conversations about how all sorts of differences are wonderful, whether it's race or culture or ability, those things are really important. I'd also say from a young age, give them autonomy as much as possible. Allow them to choose what language they want around it. I'm very passionate about saying disabled and non-disabled, because I am normal. I'm my normal, and yet too many conversations in the disability area are about the normals and us.
Yeah.
And it shouldn't be that, because that is our normal. So disabled and non-disabled. Ask your child, your young person, what language they want. Ask if they want to be in photos. Ask if they want to do things to raise awareness and how they choose to do it. I was at an event recently for people with my disability, and there was a young woman being forced to have photos because she'd always been told, you're doing your bit. And it's like, we can do our bit. Like Lily does incredible. Well, Lily's just incredible. But Lily does all these cakes and raises money for CTT and makes cards and things. And there's so many ways that people can support those charities without making us feel like victims, like we're the poor pitiable ones. So allow them the autonomy as much as possible. Obviously, there are some decisions that, we don't want to do things, and we still need to go to hospital appointments, but allow them to say, I don't like it. Of course you don't. Why would you? And as much as possible, have an equitable household. So too often in families, there's one person who'll take the disabled child to things, and then another parent or another carer will take the non-disabled child to things. Or go to as much as you can as a family, so that difference isn't focused on as much. There will always be differences, but there's no reason why someone in a wheelchair can't go and watch a non-disabled sibling playing football, just as that non-disabled football player could also go and watch their person using a mobility aid playing football. So to try to make it as equal as possible, and celebrate as much as you can about everybody in your household. And with tea and cake is always advisable. So celebrate as much as possible.
Amen to that. It's wonderful what you said there about limiting beliefs, because we met with Lily and some of the other ambassadors recently, and to talk about transition, which we'll touch on a bit later. But it actually took my breath away hearing their lived experiences of some of the outrageous limiting beliefs that people in healthcare and education had put onto them in quite stark terms. And really, it stopped me in my tracks just hearing some of the things that they'd been told. You'll never do this, you can't do that, people like you don't do those sort of things. That kind of language, setting that scene from people that they see as people in authority, that's life defining, those kind of things. So it's really nice to see that and I know you do work with these young people to help them understand their own response to that kind of thing. So thank you for that, Vi. I really appreciate it.